Hi everyone. I would like to thank Prof. Mahmoud Salah and Dr. Ahmed Sagr for the invitation. So I'll be talking about optimal treatment algorithm in acute type B aortic dissection. So I have no disclosure. So as an introduction, so acute aortic dissection is the most common life-threatening aortic emergency, with the incidence of about 6,000 to 10,000 cases annually. And type B dissection accounts for 23% to 40% of all aortic dissections. And the patients with aortic dissection, they are more than twice the mortality than their regular controls. As you can see, the old classification was there was the DeBakey classification and the Stanford, and now we move to the new SVS-STS classification, where there is type A when there is entry tear in zone 0, and type B when the entry tear is in zone 1 or beyond, and determined when the entry tear is unidentified with the involvement of zone 0. The acute type B aortic dissection subtypes, we have the uncomplicated, and then we have the complicated, and then there is the middle group, which is the high risk, the one with the high risk features. So the uncomplicated one is when there is no rupture, no malperfusion, and there is no high-risk features. Those with the complicated is the one who ruptures or they have malperfusion. The high-risk features, there are many. These are some of them, like refractory pain, refractory hypertension. There is bloody pleural effusion, aortic diameter on the initial scan more than 40 millimeter. Readmission entry tear that is at the lesser curvature, or false lumen diameter on the initial scan that's more than 22 millimeter. When we go to the chronicity classification, so there is the hyperacute, which is less than 24-hour, acute that is within the first 2 weeks, then the subacute from after 2 weeks to 3 months, and then the chronic one more than 3 months. So the acute complicated accounts for 30%, and then the 30-day mortality is about 10%, and it goes as high as 20% when there is malperfusion. Those with the complicated presentation, 2/3 of them, they come with malperfusion, whether it's in the lower extremity, in the kidney, visceral, or the spinal cord. And those who come with rupture, it accounts for about 1/3 of the acute complicated type B dissection. And even some studies reported more than that, so it can reach up to 50%. So if we look at the different society guidelines across the world, we can see that TEVAR as a first line of intervention in patients with acute complicated type B dissection is level 1 evidence with a C recommendation. And the dissection IDE trial for the acute complicated type B aortic dissection showed that at the 5-year outcome, there was 100% proximal entry tear exclusion, with 94% the true lumen was stable, and 89% with complete false lumen thrombosis, and no conversion to open repair, and with no incidence of postoperative rupture throughout the 5 years. In the acute uncomplicated, this is a very important slide, because here we can see that the burden of the disease is in the uncomplicated. So it represents about 70% of the cases. And the long-term prognosis is not as great. Also, there is 22 to 42% mortality at 5 years, and 30% rupture rate per year if the aortic diameter is more than 6 centimeter in diameter. And although the medical therapy, it might delay the progression of the disease, it does not enhance any remodeling at the level of the aorta. And the subsequent elective late aortic intervention, it happens in about 30% of these patients. So looking at the natural history for those with the uncomplicated, the Mass General, they looked at this for over 12 years. And when you look at the diagram, for those who underwent actually an intervention, there is a significant improvement in survival. And when we looked at the follow-up over the at least 5 years, there was a 58.4% who actually failed the medical therapy on the medical therapy arm, And there were also 38% mortality and 29 aortic-related re-interventions. And acute versus chronic, so treatment with TVAR in the acute aortic dissection compared to the chronic, they actually show that it is better to be done in the acute. As you can see, that complete obliteration was observed in 70% compared to 38.5% in acute versus chronic. Then there is the INSTEAD and the INSTEAD XL trial. It looked at the 2-year and the 5-year outcome of patients with type B aortic dissection at 7 European centers with 140 subjects, with primary endpoint of all-cause mortality and secondary endpoint of aortic-related mortality and disease progression. At the 2-year, there was no statistical difference on the major endpoints at 2 years. But, and this is just a picture that actually shows how there is a remodeling that happens in more than 90% of patients who undergo TVAR after 2 years. When we look at the INSTEAD XL, which is the 5-year outcome, when we look at the all-cause mortality rate, there was no significant difference. But when you look at the aortic-related mortality, there is a 12.4% absolute risk reduction, and also on the disease progression, it was statistically significant with absolute risk reduction of 19.1%. The society guidelines when it comes to early TVAR in the acute and complicated type B aortic dissection, it's a level 2A with the B recommendation in the European guidelines. And the goal of the TVAR in dissection is really to cover the tear, the entry tear, and promote false lumen thrombosis, and to improve the flow in and expansion of the true lumen, and promotion of aortic remodeling. Who are the high-risk patients? If we look at the predictors, so those are the patients who are less than 60, white race with heart rate more than 60, Marfan patients, FDG uptakes, aortic diameter more than 40, patent false lumen, partially thrombosed false lumen, even though it is debatable, proximal descending false lumen diameter that is more than 22, sac formation in partially thrombosed false lumen, one entry tear, and the other different groups. So if we look really at an algorithm, the algorithm that is currently we're using is if the patient comes in with a complicated, then they go for an emergency TVAR if they have a good landing zone. If they don't, then they go for a frozen elephant trunk. And in patients who have uncomplicated, then we look at the high-risk features. If the patient has a high-risk feature, then we go for a TVAR. And in those with no risk feature, we can observe them and continue with optimal medical therapy. So the timing of the intervention, so actually the study showed that the intervention, if it is done in the subacute phase, it has a better outcome in terms of decreasing the rate of free intervention. And what is next is the IMPROVE AD trial. And so we'll be looking at what they will show us in the future. Thank you so much.